Perfect, great. Okay, so I'd like to acknowledge that I am located in Halifax, Nova Scotia, on the ancestral and traditional land of the Mi'kmaq people. As this is a virtual event, we are all located in different places. I invite you to acknowledge where you're located in the chat if you would like and if you feel comfortable. So we're going to get into the presentation now. I'd like to introduce Dr. Sanaee. Dr. Sanaee is a board-certified obstetrician and gynecologist with the Royal College of Physicians and Surgeons of Canada and underwent advanced subspecialty fellowship training in female pelvic medicine and reconstructive surgery. Currently, she is a clinical assistant professor of obstetrics and gynecology at the University of Alberta, and her recent clinical practice includes a full-time academic urogynecology practice in Edmonton. So without further ado, Dr. Sanaee, I'll turn it over to you.
Good morning, everyone. It's morning still where I am. Maybe good afternoon to some of you. I'd love to start by thanking several people, but also a big thank you to the Abortion Rights Coalition of Canada for organizing this workshop as an act of reconciliation, and a big thank you to all of you for your participation, donations, and joining us on this beautiful Saturday morning. I'd like to thank Doctors Kristen Black, Brittany Johnson, and Rebecca Rich, who have generously given their time, knowledge, slides, edits, lived experiences, and expertise to contribute to this talk. And thank you to Wawa Teikwe, Northern Lights woman of the Bear Clan, Elder Louise McKay, for her shared wisdom, guidance, and support, and for introducing me to ARC. Everything that I share today will be coming from these key documents, and especially from this book, An Act of Genocide, Colonialism, and the Sterilization of Aboriginal Women by Dr. Karen Stote. And this is actually her thesis document. I highly recommend it, but most of what I'll talk about today will come from this document. So to begin, I would like to share what I would call something like a prayer. This is a meditation from Richard Wagamezi, Embers. To use the act of breathing to shape air into sounds that take on the context of language, that lifts and transports those who hear it, takes them beyond what they think and know, and feel, and empowers them to think and feel and know even more. We're all storytellers, really. That's what we do. That is our power as human beings, not to tell people how to think and feel and therefore know, but through our stories, allow them to discover questions within themselves. Turn off your TV and your devices and talk to each other. Share stories, be joined, transported, and transformed. So today I'm going to be sharing a story. And as promised in the introduction on the website that you might have read, we're going to review the colonial history pertaining to Indigenous women and how this history has influenced the care that Indigenous women and Two-Spirit people receive today, particularly gynecologic care. Then we're going to learn how to identify invisible policies by working through some case examples. So we will have breakout sessions with an exercise, and we'll have the question and answer at the end. At this point, I do want to mention that the subject matter presented today will be disturbing and triggering for some participants. There will be the use of strong language and heavy subject matter. Gendered language or old terminology may be used to reflect language used in historic documents. And I am learning. I have a long way to go. I am not by any means a historian or a content expert, but I am a gynecologist who in my early training did notice some discrepancies about what I was being taught, and this helped me develop an interest in learning what I'll share with you today. History of colonialism and its impact on gynecologic care today. But let's take a step back and let's go back to that chat box that everyone so wonderfully did their land acknowledgement. Does anyone know the difference between the word reserve and reservation? You can just put it in the chat. Perfect. Tasneem, you got it. So reserve is the term used in Canada. Reservation is the term used in the US. Exactly. Let's see if we can find a harder question for you. How many reserves are there in Canada? So same thing, if you can put it in the chat, that would be great. Rough estimate. Anyone have a guess? Or maybe knows? Oh, pretty close, 2,500. It is actually 3,394. So that is a very close guess, Linda. Thank you. The next question. What percentage of Canada's land mass is reserve land? And again, feel free to put it in the chat. Is it double digits, single digit percentage, under 1%, less than that? Great, some ideas in the chat. The 2 is probably was in your mind because it's 0.2, 0.2%. So if we look at this infographic that's being created by the CJPME, we can take a tour through history where in the late 1600s, the settlers from Europe started on the East Coast in what we know as Acadia, southern Quebec, and that's where the colonies were formed. And the Indigenous nations are listed here, but of course there are many more. Then we see the changes that occurred over time. So by 1763, only 82.5% was Indigenous land. And then by 1871, that Lower Canada, Upper Canada, as well as British Columbia, which was ceded, was part of what we call Canada, because we remember that Confederation in Canada was in 1867. So this is now Canada. And then today, the reserve land is about 0.2%. So we're going to take a tour through history a bit to understand the role of Indigenous women once those first colonizers arrived, and then bring us to where we are today. So during those early years, colonizers were actually encouraged to marry, have relations, and in the historic documents, the term commingle is there with Indigenous women. And this was written policy and was highly encouraged. And it was seen as a tactic to assimilate and learn the ways of the land. And it was actually very economically advantageous to the fur trade, because by learning the land, by participating in hunting and such, this was very helpful to the colonies. And actually at that point, and we're talking about, 1700s, 1800, early 1800s, this was a seemingly friendly exchange, and there was autonomy and respect on both sides. What's interesting here in Edmonton is we have something called Fort Edmonton. And it's, where you can go to see what the early settlers lived like. And there's a blacksmith, and you can churn your own butter. And there's an actual fort. And that is the historic fort from the early days of colonization. And many were very disturbed why this marker of colonial history is so present in Edmonton. But actually, the response was very interesting. We now have an Indigenous Persons Experience Pavilion, and it reminds us that half of the people who lived in that fort were Indigenous women. And so the role of Indigenous women in creating societies, in creating the society in which we live in today, is very important and present, and we actually have to learn about it and acknowledge it. Because at that point, no white women had moved this far west yet. And here are two quotations. Due to their central position in Aboriginal societies, alliances were sought with Indigenous women in order to infiltrate communities and establish trade relations and to gain access to Aboriginal lands and resources. This is Sylvia Van Kirk, who is an associate professor at the University of Toronto, I believe, in gender studies. And then the next quotation, it was common practice for fur traders and resident officers at trading posts in the interior of Canada to have sexual relationships with influential Indian women as a means of developing and maintaining trade relations with surrounding Indian groups. So as we're talking about this, it is really important to think of how these were the ancestors. These were the women who helped shape Canada and our society. And we can take a moment to reflect on that. These women were interpreters, diplomats, negotiators, peacekeepers, and they were highly valued and respected. However, things changed. After the fall of the fur trade in the 1850s, it was no longer advantageous or strategic to have colonizers commingle with Indigenous women. Economic advantage shifted. It would instead come from land mass accumulation. And it would be easier to take land if there were no Indigenous people to defend that land. So we can see that by 1850, when this was in the newspapers, that urgent request, thousands of nice girls are wanted in the Canadian West. So this was advertised in the Canadian East, in Europe. Over 20,000 men are sighing for what they cannot get. Wives, shame, do not hesitate, come at once. If you cannot come, send your sisters. So great is the demand that anything in a skirt stands a chance. No reasonable offer refused. They are all shy but willing. All prizes, no blanks. Hurry up now, girls. Do not miss the chance. Some of you will never get another. So these kinds of advertisements to white women in the East were coming out because no longer was that strategy or plan to have Indigenous women become wives or part of the family. That was not the strategy anymore. So all these policies that were in place came together and took the shape of an act, the Indian Act of 1876. And this act, of course, is a whole talk on its own, but the overarching goal that we can see, or the themes, would be removing the Indian problem via different tactics. So let's again think of the times that we're in. So in the 1850s, that's the fall of the fur trade. 1867 was Canadian Confederation. What was happening south of the Canadian border at that time? So in 1867 was the abolition of slavery in the US. But years before that, in 1808, it was the abolition of international slave trade among the British Empire. So this is where we are seeing what the historic goals were and that racism is not an accident. If we acknowledge and understand the objectives of the North American colonizers and the founding fathers, we understand that what has happened to Indigenous and Black women over the past 2 centuries was calculated and went according to plan. So for Indigenous women, they would give birth to Indigenous children, and this was not desired because there was an economic disadvantage to have Indigenous people defend their land. For Black women, they would give birth to future more enslaved people, and this was desired because this was an economic advantage. So North America was built on racially differentiated policies toward reproduction. Black women faced coerced reproduction. There was a significant economic interest in the fertility of Black people for the 250 years of slavery. And this was augmented, remember I mentioned in 1808, because no longer could there be any enslaved people sent from Africa to the United States. That was abolished. So any people who were born in the US who could be slave, that would be ideal. So that's where the labor supply came from. That's where higher property values came from. And unfortunately, that truth and the history of gynecology is that a lot of what we know about gynecology today came from gynecologic experiments on Black women in the South. And knowledge of birth control was held, and there were sexual acts and incentives in place to coerce enslaved women into reproducing. Abortion was actually an important tool leveraged by enslaved women to control their fertility and prevent future children from experiencing horrific, inhumane conditions of chattel slavery. So we see this racially differentiated policy toward reproduction, and all of this is laid out in different acts, bills, and documented government reports. Indigenous women became the target to play out the strategy to dismantle the Indigenous family, tribe, nation, and therefore people. Eroding the position of Aboriginal women as caregivers, nurturers, and equal members of the community inflamed the false colonial perception that Aboriginal women were somehow worthless and free to be exploited. So that shift in 1850 really solidified by the Indian Act in 1876, started to create and lay the foundation for what we see today. This includes the narrative about Aboriginal women. And it changed. The first Prime Minister of Canada says, the depravity existing among the Indian women is greatly deplored. They repair on arriving at years of puberty to the white centers and enter into lives of prostitution. These women were labeled immoral, a threat to the public, blamed for their failure to adopt civilized Christian marriage. The Indian Act and Criminal Code specifically included legislation to ban prostitution of Indigenous women. This wasn't even happening, and prevent their travel outside of reserves and loitering on white settlements. The Northwest Mounted Police would enforce surveillance and arrests if these women were found outside of reserves. And of course, the Northwest Mounted Police is the predecessor of the RCMP. There were purported narrative paintings of Aboriginal women as hypersexualized, drunken, easy, and dirty. So all of this started to permeate different beliefs and institutions. And this narrative became, how could she be a fit mother? The criminalization of simply being an Indigenous woman led to the labeling of bad mothers, unfit to care for their children. So again, let's go to the chat box. What policies do you think became acceptable based on this narrative and belief? And how is this narrative still pervasive today? Really good. So again, the question was, what policies do you think became acceptable based on this narrative and belief, and how is this narrative still pervasive today? Residential schools, child welfare, 60 scoop, coerced sterilization, taking children away from mothers and into white families, removal of Indigenous children from families seen in residential schools and 60 scoop, apprehension, residential school system, definitely. Yes, forced birth evacuation, missing and murdered Indigenous women and girls, carceral systems, definitely. Birth alerts, excellent. So you've captured so many. And this disturbing but powerful painting by Kent Monkman, The Scream in 2017, shows the redcoats coming to take the children away. And some of the elders I've spoken to definitely remember this and how they would hide their children when it was time to have them taken to school. So if we think about the policy of residential school system, 60 scoop or forced sterilization, we see that there's an equal yet persistent legacy that continues today with birth alerts in the child welfare system and missing and murdered Indigenous women, girls, and Two-Spirit plus. For the purposes of today, we're going to focus on forced sterilization. So medicine was not immune to this narrative that was being told and perpetuated in every institution, every structural system disseminated by government, society, and the initial colonialist approach. And the four big categories of reproductive racism, they all have their roots in biologic inferiority. So you can see that's lack of hygiene, intellectual inferiority, hypersexuality, superhuman pain tolerance, and an actual anatomic inferiority of the pelvis. And that narrative of hypersexuality, prostitution, that has led to sexual violence and what we see today, that is where we're going to focus on now. So again, let's think of where we're at. So, okay, Canada is founded, Indian Act is in place, the narrative is being told. And in 1907, in the United States, that was the first sterilization law. In 1910, the American Breeders Association and the Eugenics Records Office was established. And between 1907 and 1977, 70,000 forced sterilizations in the United States were recorded. And of course, we know that there were much more that were not recorded. And again, to see where, I mean, as physicians, we think, we're people of science, we are not influenced by these sort of things. But you can see by 1933, 50% of medical professionals in Germany had joined the Nazi Party, and many participated in euthanasia, forced abortion, or forced sterilization as part of the public health campaign of Rassenhygiene, which would be race hygiene. What about in Canada? Well, this was aimed at improving the human race through selective breeding and actively encouraging reproduction of some women while discouraging and preventing reproduction in others. And the Eugenics Society of Canada was established in 1930. And actually, there were physicians in Canada who went to Germany to learn about this and brought it back. And it gained popularity. Academics and physicians worked together, and that's where the Sexual Sterilization Act came into play. There were both compulsory arms and optional arms. 3,000 recorded forced sterilizations were performed, and there was an amendment in 1937 where you did not actually need consent if the person in question was deemed mentally defective. And 77% of Indigenous children who were sterilized were labeled mentally defective. When we look at the numbers, Indigenous peoples made up 2.3% of Alberta's population at the time, but made up 25% of sterilizations performed. And here it is, the bill number 51 of 1928, the Sexual Sterilization Act. And you can see this is just the first page that I took a picture of, saying that it's the Legislative Assembly of the Province of Alberta. This is the act. This is how it's carried out. And it was in effect from 1928 to 1972. Over 1,000 women were sterilized under this act. And like I mentioned, Indigenous women accounted for over 25% of the sterilizations. In 1937 was when I mentioned that the need for consent was removed. What about other provinces? British Columbia, same thing. Sterilization Act 1933 to 1973. The Eugenics Board could approve sterilization of institutionalized persons who may bear offspring with a mental deficiency. Again, the estimates are 200 to 400 people were sterilized under this act. And other provinces did have drafted acts, but they were not approved. Saskatchewan, Manitoba, Ontario, actually from the opposition of the Catholic Church. But we do know from records of witnesses and those who performed the sterilizations that these did happen. They were just not recorded as systematically as the province where the acts were in place. And then finally, this came to an end because of a Supreme Court of Canada decision in 1986, E versus Eve, where Mrs. E applied to the court for permission to sterilize her 24-year-old daughter who had an intellectual disability. But ultimately, this was denied because the surgery was deemed not necessary, not therapeutic. And so that actually put an end to all of it. So then the tactics had to change. Forced sterilization was no longer the law or allowed or condoned, but birth control recommendations were just disproportionate to Indigenous women and girls. And the instructions, whether it was from different government officials, and this is what is all documented in Dr. Stote's dissertation that I mentioned at the beginning, the instructions were to start at 14 years of age. And this is very well documented for Inuit women, and there's good documentation in Northwest Territories as well. IUDs were in letter correspondences. IUDs were preferred due to fear of oral contraceptive pill non-compliance. And abortion was considered legal if the pregnancy was determined unhealthy in any way. And again, there was a huge disproportionate number of unhealthy pregnancies recorded for Indigenous women compared to white women. So we moved from that sterilization to other methods to control reproduction. So let's take a little break and have a summary here of the colonial effect on Indigenous women. The status as leader and matriarch was stripped. The label of hypersexual, unfit for motherhood became predominant. The government forcibly had policies to forcibly remove children from their families and families from their land. And this was socially accepted, condoned, and enacted policies to sterilize Indigenous women. Formal policies were disbanded, and invisible policies took their place. And Indigenous women and gender diverse individuals were systematically targeted for sex trafficking, victimized for sexual violence. Again, this is all very heavy, and so we're going to take a moment to remember the missing and murdered women and girls and two-spirit people who are no longer with us, and realize that this was not an accident. Their destiny was predetermined hundreds of years before they were born. The report, the National Inquiry into Missing and Murdered Indigenous Women, Girls, and Two-Spirit individuals, this document outlines 4 pathways that maintain this colonial violence. The first is the historical, multi-generational, and intergenerational trauma, the social and economic marginalization, which is the fallout that has happened from this history, and then maintaining the status quo and institutional lack of will to change. And finally, ignoring the agency and expertise of Indigenous women, girls, and 2S LGBTQIA people. This is what we mean by institutionalized racism. It's the differential access to the goods, services, and opportunities of society by race. It's normalized, it's legalized, it's inherited disadvantage, it's structural. It's codified in our institutions of custom, practice, and law. And the sneaky and purposeful part is that there's no identifiable perpetrator, or it's very hard to pin it all on one person. It's evident as inaction in the face of need. It is important to note that the association between socioeconomic status and race, I changed it because this comes from a document from the United States, but in Canada, I agree is the same, has its origins in discrete historical events, but persists because of contemporary structural factors that perpetuate those historical injustices. In other words, it's because of institutionalized racism that there is an association between socioeconomic status and race in this country. Dr. Karen Lawford published this critical document in 2016 in the Atlantis, and it's called Locating Invisible Policies. She describes how to find policies driving institutions even if they are not formally written or purposefully introduced only in obscure locations. She describes many different definitions of what a policy is, and the first one she uses is from Thomas Dye, and it says, "A policy is whatever governments choose to do or not to do." And her suggestion is that you can find these invisible policies by looking at where are the resources allocated, what are the material impacts, and what is the reaction? And that will tell you what the policy is. What is allocation of resources? Well, it could be economic resources, human resources, or otherwise. And this reveals the government intentions. Basically, follow the money. Material impacts. These can be tangible physical impacts. They're the consequences on the constituents. And finally, the reaction is usually the reaction of those who are impacted by this invisible policy. So it could be an agency, it could be scholars. So you can look for any guidelines or protocols related to the subject, and that might tell you what the reaction is. And when you put all this together, you can see what the policy of our country is on a certain topic. So she uses the example of the invisible evacuation policy, and I think that that was mentioned in the chat earlier. So the evacuation policy is referring to how basically no individual living on most reserves were born on that land. They all are evacuated at around 37, 38 weeks of gestation in their pregnancy to a major center. And that's where that term estimated date of confinement comes from. So their due date being 40 weeks, are there, usually by themselves, sometimes with a support person, taken away from their land and their community and their support system, deliver, usually alone, and then held for a few days for postpartum and then sent back. And when Dr. Lawford looked at this more carefully, where did this policy come into place? How come every reserve in Northern Canada or in Canada has this policy? And if we look, we can see what she found. So allocation of resources. Well, all the funding for birthing and maternity goes to provinces, yet reserves are federally funded. And funding goes to transport of the pregnant person to and from reserve. So that's where the money is. What is the impact? Well, no individual living on the reserve is born there. And that is a very tactical and painful targeting because we know for Indigenous people, the relationship to the land is directly tied to relationship to health. There's a sense of loneliness, boredom, and isolation. There's a lack of connection to supports. There's a lack of sharing of traditional knowledge around birthing, and this impinges on self-determination. And if the patient, the woman, the client refuses to go to deliver, say in the big city, this is met with a narrative of being an irresponsible mother. And what is the reaction? Interesting, it's a policy that midwives cannot be federally employed. And you can see how that ties in here. So if you can't have any midwives who are federally employed and you can only have physicians and nurses, that's where things changed for Aboriginal midwifery. And everything comes back to, well, universal healthcare. All Canadians have to have the right to equal care. So having that access to an emergency C-section, so using that reaction or response as the reason to bring all pregnant people at the end of their pregnancy from reserve to the big city, that's kind of the reaction given. So when you put all this together, you can understand what the policy is. So Dr. Lawford's conclusion is that the invisible evacuation policy aligns with the same historic assimilation policies. And that it's no different. It just is yet another policy that supports the original Indian Act and the original plans for Indigenous peoples in this nation. How's everyone doing? Any comments or thoughts at this point? We're going to take a deeper dive into the subject of forced and coerced sterilization today. Just going to have a look at the chat. Okay, looks good. I'm going to tell the story of Leilani Moore because it just shows us that this is not history. This is now. Leilani was sent to the Provincial Training School for Mental Defectives, also known as the Michener Center in Red Deer in Alberta, at the age of 10. Much like many Indigenous children were taken from their homes and sent to different training schools, residential schools. Admission required parental signature permitting compulsory sterilization. So that was, you're going to school, here are the forms, you're also going to sign the line about permitting compulsory sterilization. And for that to be done without consent, remember, you would need the diagnosis of a mentally defective moron. And they did do IQ testing, except a lot of these children didn't speak English, and the testing was in English. So the majority were deemed mentally defective. So Leilani had both of her tubes out at the age of 10, and she was told, and her family were told, that the surgery was actually to remove her appendix. So after years of suffering from infertility with her partner in the future, did she have tests and learn that this is what had happened? And also being labeled as a mentally defective moron had a huge emotional toll on her for her whole life. And she did retake the IQ test as an adult and actually was above average. Finally, there was a 4-week trial ruled in her favor, and she received $740,000 in damages plus legal costs. And nearly 850 Albertans have been awarded damages. She just passed away in 2016. So again, this is not remote history that is so far from our understanding and reality. This is now. These are our contemporary family, patients, people will meet day to day. And in 2018, you can find articles that state Indigenous women come forward with accounts of forced sterilization. Lawyer says sterilization without informed consent has been performed as recently as 2018 in Saskatchewan. So you see articles like this and you have to think, well, who are performing these surgeries? So yeah, who is performing this? Well, it's my colleague, it's us. It's a gynecologist doing this. And so these are my colleagues, my teachers, these are doctors who unknowingly, somehow, how could it be unknowing, have continued the perpetrated narrative that was started at that 1850, 1860 mark. And how is this similar or different to other violent acts of reproduction, including missing and murdered Indigenous women? So in 2017, when all this was coming out, an external review of tubal ligation meaning either clipping or removing the tubes or tying the tubes, or they're not actually tied like a knot, but somehow blocked. So they could be with clips, it could be with an electrosurgical device clamped and then burned, so that you're disrupting where the ovary is releasing an egg to where the uterus can grow the baby. So you're disrupting that tube. So all of that would be considered tubal ligation. So this external review was done at the request of the Saskatoon Health Region. And it's also called the Boyer and Bartlett Report of 2017. And these were interviews with women in this region. And themes were identified, including feeling invisible, profiled, and powerless, experiencing coercion, ongoing personal impacts of self-image, relationships, and healthcare, and experiencing an abuse of power. There was misrepresentation of permanency of sterilization and lack of other options for birth control. I refused the tubal so many times that they had the doctor and another person come in and say, it's just clamps and we can remove them. And for those of you who know, these clamps, these filshy clips that you use to clip tubes, if you want to remove them, then you need to do a $8,000 private surgery to try to bring those tubes together. This is permanent. That is very extraordinary circumstances where you're going to try to do that. In these interviews, the women reported that while in hospital and many in active labor, they were given little to no information about what tubal ligation was or about its consequences for reproductive health. Just now, I'm going to say in the last 5 years, we're learning that just by tying your tubes or clamping the tubes, having a tubal ligation might actually change the blood flow to the ovaries, which can bring on menopause sooner. And this research is just being done now, and so these consequences, nobody is being counseled on these. Intimidated by scare tactics and pressured into signing consent forms, discriminated against because of their race, threatened that their children would be taken away. And this is the ugly truth that I would say, I went through residency training in obstetrics and gynecology between 2011 and 2016. And these are the kind of things that you would see. And it was just under the radar, but the way that the physicians would counsel the patients and us as trainees would watch this, the narrative of, oh, all their kids are in care. So, they don't need more kids, or, oh, wow, they have this many kids. Oh, yeah, that's too much. Like, who are we to make that decision? But definitely that was the teaching that we got. And then that would be what the counseling was. So that threat to have their children taken away, but their children taken away is based on a system that is exactly the same history. It just makes no sense. And then alienated by healthcare providers and the healthcare system, often feeling invisible and forcibly sterilized. I can imagine and remember during a C-section, the OBGYN just putting down the curtain and saying, you sure you don't want your tubes tied? After many times the woman saying she does not want that. And saying, it's your last chance, even if it's in a joking way. It just gets really burdensome on the patient. Forcibly sterilized despite saying, no, the consent form for tubal ligation was just given to me, not explained, or I refused right up to the very end, like the morning. You need to sign. I didn't want to, even on the table. So what do women understand about tubal ligation? A survey of 193 women compared to white women, racialized women were less likely to have heard of other methods of contraception, more likely to believe that tubal ligation could be easily reversed or that it could reverse itself. And the conclusion is that the conclusion of this paper was that there is higher levels of contraceptive misinformation. And likely that's a bias in counseling. Another study from 2011 shows us the implicit bias of the gynecologist. Stereotypes help our brains process and store information, categorize patients into a specific group, and all the beliefs about members of that group come flooding in. So these are unconscious stereotypes, subconscious stereotypes that contribute to disparities in healthcare outcomes. And we all have stereotypes and biases, but the colonial history is alive and well. First step is to be aware of this implicit bias and acknowledge that it does impact our delivery of patient care. So even in contraceptive counseling, the survey of women belonging to racialized groups revealed themes of negative contraceptive counseling, feeling ignored, experiencing coercion, discrimination, and women highlighted the importance of patient-centered care. Feeling their opinions were listened to and respected would be what they would want, and many appreciated having written information with pictures. Okay, oopsie. So now that we're putting all this together, we're going to go into breakout rooms and work on using Dr. Lawford's method of taking a policy that we think is a policy, but likely an invisible one, and breaking it down to come up with the full policy. So how do these historic narratives about Indigenous women affect physicians today, and how are the goals of the colonizers perpetuated today? We saw this example in family planning counseling. So the question to you all now is, what is the invisible policy on forced sterilization or coerced sterilization of Indigenous women? So this is what we're going to fill out together after you've had a chance to talk in your breakout rooms. So again, the task at hand is the invisible policy of forced and coerced sterilization. I want you all to brainstorm with your group. Where are the resources going for this? What are the impacts of this? And what is the reaction of this? Sound good? We will come back in about, oh, sure, there's a question to show the example of the invisible policy. Absolutely. And I will come into the breakout rooms to show you all, but I'm going to just go back to that slide. So here it is. So remember, allocation of resources can be economic resources, human resources. Material impacts are like the consequences of this policy. And then the reaction is usually that of agencies or scholars. If there's any guidelines or protocols about it, that also can show you what a reaction to this happening would be. And the example was that of the evacuation policy of pregnant patients. And this is showing, for example, that maternity funding is provincial, whereas reserve funding is federal, and the impacts of what happens when none of the babies are born on the land that they live, and then the policies that are found that are the reaction. And I mean, it's a little unfair because you might not know any of these policies, or sorry, government reports or any reactions, but you can imagine them. So as a group, you can imagine them, and you can also use Google too. So that's the example that we went through earlier. So oh, I almost showed you the answers. So again, we're going to go into groups and just brainstorm on what you think the allocation of resources is for perpetuating this forced and coerced sterilization, the material impact. So what are the consequences of this happening to Canadian society, Indigenous women, the Indigenous nations, to sovereignty, any material impacts you can think of, and then what may the reaction have been over the years to this happening. I'll give you a clue, like I showed you that Saskatchewan Health Authority report. So you have about 7-ish minutes in your group, and we'll come back and wrap it up. 5 minutes. Thank you. The recommendation to turn to court systems for compensation like Leilani Moore did, but you're turning to the same system that hurt you in the first place. And the Royal Commission on Aboriginal Peoples of 1988 created an Aboriginal Healing Foundation to heal those who were victims of forced sterilization, but the funding was cut in 2010. This is art by Lisa Boivin, who is a Métis digital artist. Please check out her work. And she shows us this image of a speculum covered in flowers. Much harm has been done in the past. We must remember this and proceed with caution in the future. Don't swing the pendulum too hard. It is one thing to refer to eugenic sterilization as shameful and unjust, but that we cannot paint all sterilizations as coercive. To do so is to deny the agency of Aboriginal women to make choices about their own reproduction and continues the paternalism so rampant in past Indian policy. So to my colleagues who say, oh, I'll never mention the word sterilization to an Indigenous woman, or, oh, I'll never prescribe them any sort of birth control. Well, that's also just as bad. It's all about that agency, the proper counseling, and having the informed choice. Mistrust in the healthcare system is deserved. I don't trust anybody. It's doctors who are white and educated against Native women. This can contribute to lack of preventative care, avoiding healthcare system, delayed presentations for concerns, and we now have to work on shifting this mistrust to trust and disengagement to engagement. And this is where I want to show you the calls to action of the Truth and Reconciliation Commission of Canada. The one that I have the most influence over and that we work on the most is number 6, increased number of Aboriginal healthcare workers. So we have pathways to admit Indigenous students and residents into OBGYN, and we'll continue to do this in the medical school. And then we also have calls to action from the National Inquiry on Missing and Murdered Indigenous Women, Girls, and Two-Spirit individuals. And this is where we can see we again have recommendations that we must follow, and calling upon governments and healthcare providers and what we should do here. I am rushing a little because I'm just going to get to the summary slide, which shows us that the awareness of this history is essential in providing comprehensive care to Indigenous patients. We all have implicit bias shaped by centuries of colonial agenda. The Indigenous peoples must be celebrated, invisible policies can be called out, and work by organizations like the Abortion Rights Coalition of Canada will continue to make a huge impact. Is it okay to open for questions, or are we in trouble because I went over time?
Yeah, but no, we're doing great. So if you're ready to go into questions, we'll say a big thank you so much, Dr. Sanaee, for the incredible presentation. And we have about 15 minutes for a moderated Q&A. So if people have questions that they would like to ask, feel free to use the little hand icon, and I can let you know when you can ask your question to Dr. Sanaee, or if you'd prefer to put it in the chat, I'm more than happy to read them out.